Okay, thank you, Diana, and thank you for inviting me to speak here today on this topic, which is quite niche, and so I'm really pleased you've all come forward a little bit, because I did look at a very full lecture theatre this morning for David Cool, who was fantastic. What a great speaker. And I thought, I don't think I'm going to fill the lecture theatre on Zika virus, but those of you who come, thank you, and hopefully you'll enjoy this talk that I'm going to be giving. Please feel free to ask questions, and if you want to stop me partway through, I'm happy to ask questions. We're quite a small group, so that should be really straightforward. Just to say, I'm an obstetrician and gynecologist, and I know, of course, Diana's sister, Robin North, very well, who is a physician. So we kind of cross over slightly, but slightly different what we do. So I come from an obstetrics background, and then I subspecialised in maternal fetal medicine, which is a bit of a mouthful, anyway. But I do have a big interest in obstetrics and pregnancy in general. So despite working at the very pointy end of our specialty and a subspecialty, I have a big interest in teaching and training around how to get the best out of women's healthcare in terms of pregnancy and outcomes. So I've done a bit of work in Bhutan in the Himalayas, helping them, and also in China currently. So this is a very interesting topic. So, I have to declare I have a conflict of interest. I'm a bit entrepreneurial as well. So I do a bit of private scanning. I work with a supplement company, and I sell organic sanitary pads and tampons. There you go. So I'm a little bit of an organic sort of environmental freak. So what are we going to be doing? I'm going to do a bit of an overview of the timeline as it occurred in New Zealand. I'm going to tell you what the Zika virus is. Then we're going to talk about what happens if someone presents antenatally. And I've got just one slide on the neonatal presentation, which I've done in conjunction with some of my paediatric colleagues. Then I'm going to come down to that advice, which dies, she's pretty much stolen my thunder a little bit with some of the advice, but there'll be a little bit more there. And then I've got a couple of cases, just theoretical cases to run through, back to that theme of what you might see on Monday morning. I'm really not expecting anyone to see a Zika case Monday morning, but I'm hoping to be prepared just in case. So this is The Guardian, but if you had read any online paper on the 1st of February 2016, pretty much this sort of headline was what you would have woken up to. There had been increasing number of cases of microcephaly occurring in mainly Brazil, but also some other South American countries in the preceding 6 months. And there had been increasing concern amongst the obstetric and paediatric community about why this might be with further investigation. It became apparent that these cases were clustered around cases of infections with Zika virus. At this point in time, though, there was no clear linkage with the microcephaly and the Zika virus. It was an assumed linkage based on the Zika cases and the microcephaly cases. And so this hit the headlines on the 1st of February, and it was declared by the World Health Organization a public health emergency of international concern. Now, I thought in a way that Zika is Zika, but actually a PHEIC is the sort of thing that will happen every, maybe 2 to 5 years, and when it does happen, it's going to hit our headlines. So it's quite good, I thought, to have an understanding of how we respond to it and how we deal with it, because it is a very difficult situation with social media and media the way it is now. This information flies through the public, and as primary healthcare physicians and nurses, you're often on the front line of people's anxiety as they walk into your room the next morning. On a personal note, I had been at, applying for my sabbatical. I had a 3-month sabbatical. I had all these great plans. I was doing some update days. I was doing some information leaflets. I had a trip planned to Houston to a fetal medicine unit. I had a conference on cardiac disease and pregnancy in Vegas. I mean, it was great. I was like, yay, But I have 2 roles. I have one role as clinical director of the New Zealand Maternal Fetal Medicine Network, and I'm the media spokesperson for the New Zealand College of ONG. So that Monday coincided with a sudden urgent requirement for me to take up 2 of those roles and become the spokesperson on television for the Zika virus. And so I ended up having to have an interview and talk about what precautions women should take. So at this point in time, women had holidays booked. They were on holiday. They had, all these plans. And so women were starting to worry about what should they do. And at that time, we were just saying, yes, DEET is safe. Yes, you do need to cover up. Yes, you need to avoid early morning and late evening because that's when they bite. So we quite quickly had something out on the TV. I then had 2 days later a phone call from the Ministry of Health saying, right, we're putting together a Z-tag. I thought, oh, do I get a t-shirt for this? This sounds really exciting. I'm part of the Z-tag. But that stands for the Zika Technical Advisory Group. So we very quickly convened the Z-tag, and there was a group of us who were then trying to look at ways of managing this PHEIC that we had all become part of. Now, it was great because actually I have to say that I really take my hat off to the Ministry of Health because they did a fantastic job in very difficult circumstances where there was a lot of panic and a lot of people wanting answers and wanting guidelines straight away when actually there was very little information. Remember, at this point, we still hadn't had definitive proof that Zika virus was the organism causing microcephaly. So we were very much working in the dark with new information coming all the time. And I think if we have more of these types of international problems, then that's often the way that things go. So our MDT, as you can see there, included a primary health physician. It included radiology, pediatrics, midwifery. We had one each of those, apart from infectious diseases. There were 20 infectious diseases specialists. So it became quite a complex group in that the midwifery and myself and the pediatrics and GP, we all kind of agreed fairly quickly, but 20 infectious diseases people found it quite hard to agree. So I left them to decide on what the investigation should be. So we had TV, teleconferences, emails, and pretty much the whole first 3 weeks of my sabbatical kind of disappeared into this whole of Zika. So I was actually the right person to ask to talk about this. So we managed to get some initial advice out on the Ministry of Health website. Zika was made a notifiable disease, and that was very much the early stages of what we did. At that particular time, now that people were testing for it, we had 3 labs that could test for it, but there was a lot of difference about how they did the tests and whether there was overlap and so on and so forth. We had already identified 9 cases. They were all non-pregnant, and 4 were from Samoa, 4 from Tonga, and 1 of these people had developed Guillain-Barré. So having developed our nationwide advisory, within my field of maternal fetal medicine, we were the people who were going to see the women where they were testing positive, and so we were going to see them. So we developed a little bit of a guideline in-house in fetal medicines, how we're going to manage them, and at this point in time, we didn't know if amniotic fluid would contain Zika virus, we didn't know when it would contain Zika virus, we didn't know the right time to do it. It was a real mess, so we're all reading the literature trying to work out what to do, but we developed a guideline so at least we knew what we were doing. And we had a database that we kept, and we cross-referenced with infectious diseases. So we're all working together to actually keep track of all these cases. So despite the fact it might have looked disorganized, there was hopefully some organization behind it. We also had the first pregnancy case at the end of February, and by June 2016, as you can see, we'd had 8 cases of maternal infection. Now, not all of those women elected to have amniocentesis. Some of them elected just to have scans, and if everything was fine, they were happy with that. We had 1 confirmed case on amniocentesis. What happened over that first 6 months was that women who were New Zealand residents but were currently residing in Samoa and Tonga who were pregnant all started to come back. So we had this massive influx of women coming back. We had doctors trying to manage them. We had fetal medicine trying to manage them. And so it was a really tricky time of trying to work out what the best thing to do. We also had the Rio Olympics, so I ended up being asked questions by people who were looking after women who were involved with the Olympics and maybe in the support teams, even a pregnant woman who was still planning to go to the Olympics. So all of this as well was part of what we were trying to deal with, not just our women coming from our Pacific Islands. So less women travelled. Women actually got the idea that it was not a good idea to travel. They reduced their plans, and that helped to actually stop that influx of women who were concerned. But to add to the complication, as we've heard, in July, then that was the first time that Zika was identified in semen. And actually, we still don't know for sure how long the virus is present. Like anything else, virus shedding will vary from person to person, but it could be longer than 2 months, and certainly putting a longer date on it means that you're less likely to have missed that person who sheds virus for a lot longer. And so we now had new advice, and we had an updated advice about now we actually need to think about partners and partners of women planning pregnancy or women who are pregnant and the chances of them passing it on. And our first human-to-human transfer cases were starting to emerge around the world. And so suddenly this was no longer just keep out of a zone where you might get a mosquito bite by an infected mosquito. This was now, okay, anybody involved with a sexual relationship now has to start thinking about that as well. So it made everything more complicated. And you may remember the Rio competitors, a couple of the men stepped down and everyone was like, oh, they must be planning to have a baby. So it kind of, you know, it became this much more complex thing. The other thing was that around this time was that actually the first paper got published, which actually conclusively showed that the reason for the microcephaly was the Zika virus. They identified Zika in the brain of an infant who'd been terminated in South America that contained PCR Zika virus. The mum had Zika virus. So this is what our data in New Zealand looks like. So from the 1st of February, when that public health emergency of international concern was first alerted, until the end of October where it finished, then we actually had 99 cases notified of Zika virus. So these are people who'd had blood tests and tested positive for Zika virus. 69 were women, and mainly in the 25 to 44 years age group. Now, obviously, this is higher proportion than men, but this will be because of ascertainment bias. So the people who got tested are the women of childbearing age in general rather than men. All of these cases but one were acquired overseas, and if you look at the table there, you can see that very much our cases came from Tonga and Samoa, where it was found that the mosquitoes were carrying Zika virus. A few other cases from other countries, mainly from people having been on holidays or travelling. But once women had come back from Tonga and Samoa, and then Tonga and Samoan women stopped going on holiday back home to the islands, then we started to see a drop-off in cases. So that peak was very much in February, at the time when we first had it, and then after that, the number of cases has fallen off. And I saw quite a few anxious people at that time, but we're seeing very few now. So on the 18th of November, the World Health Organization declared that the emergency was over and that Zika had now become business as usual. Still a lot of work ongoing about how to stop the mosquito continuing to support the Zika virus. Certainly one approach has been to clear all the swamplands and try and reduce the mosquito infestation, but I think it's clear you're never going to get rid of mosquitoes. They're always going to be there. And so now there's some new work, which I didn't put too much on this, but there's new work using genetic modification. The question is whether it's something we want in the world or not, using some new CRISPR-type technology to actually change the way that the mosquito's genome can actually support it being infected by a virus such as Zika. And that may have real benefit because the Zika has been so catastrophic. Everyone has got on with this technology for Zika, but if you can actually change the mosquito genome for Zika, then you can probably do things like change it for malaria and other conditions which are really major world health issues. Okay, so it's all over. What now? I can get back to my sabbatical? Maybe not. I've missed out on that. I thought I would just say, well, what is the Zika virus? It's a flavivirus, so it's in the same group as yellow fever and dengue fever, and it's infected by the mosquito biting you. Now these mosquitoes only live in warm climates, so that's why we don't have it in New Zealand. We're too cold here, and so this mosquito is not going to survive here. So that's good for us, and that's why we didn't see it here. We know now that it can be sexually transmitted. We didn't know that a year ago. And I've said it can remain in the semen for up to ? There's still ongoing research. But as often happens with these things, once the emergency is over, and so it's a little bit like the, I'm just trying to think what it was. Anyway, yes, the other one. Then what happens is that research interest dies out again. And so, everyone stopped publishing papers on it now. So there was February, there was no papers. March, there was 2. April, May, June, heaps and heaps, more and more and more. And now it's all just going away again. So the urgency has gone, but I suspect that we do need to think carefully that could be in seam of quite some time. So if you're going to work on Monday and someone says, I've just got back from Tonga and they feel unwell, these are the sort of symptoms. Well, they're very nondescript. They could be any sort of infection, fever, vomiting, rash, joint pains. They're pretty much the sort of thing that you might see all the time, which is why it's important to know a bit about where someone has been. So 4 out of 5 people will be asymptomatic. And when we think about pregnancy as a fetal medicine specialist, to me this feels very much like CMV or toxoplasmosis, that someone pitches up and, you know, most of the time they don't even remember having any symptoms at all. Of course, one of the fears around the world is that one of the consequences of having Zika is Guillain-Barré, and so there's not, as I say, been only a couple of cases of this, but obviously very serious. In terms of fetal manifestations, we're going to see a very small head, but that's not the only thing, where you will also sometimes see stuff intracranially as well. The investigations are a reverse transcriptase PCR, so that's actually looking for virus within the blood or urine, and it tends to be in the blood for 7 days and urine for 14 days. And we're not currently recommending serology in New Zealand. I'll come back to that in a minute. So, antenatal presentation. So I think you have to take a history. So obviously, if someone has not been off New Zealand and their partner has not been off New Zealand, then you can reassure them. I don't think you have Zika. So that's the first thing. It might be that they come with having just been to a Pacific island or an infected country and now they're pregnant and they got pregnant while they were there and they're worrying about it. It might be their partner has been, or it might be that they've had a scan in the community and the sonographer has identified some things on the scan which could be Zika virus. If you're talking about microcephaly, what we're seeing with the Zika virus tends to be very severe. And when we're doing an ultrasound, we'll plot head measurements out, and I'll often have a baby with the biparietal diameter and the head circumference are just on the 5th centile, and I've had people say, could this be Zika? You know, really anxious, and actually it's just part of the normal range. If you're going to have microcephaly, it has to be well below that. It has to be below the 3rd centile, and that would be your sort of your typical microcephaly. What they've tended to see overseas is they've seen the very severe, so that would be very obvious on scan. It was not just on the 5th centile. This is some of the images that people have seen, and for me, in fetal medicine, they very much cross over with what we see, particularly in CMV. So the left-hand images are, the top left one is a normal ultrasound of a fetal brain. And hang on, the top left one, no, I'm looking down here, the top left one is abnormal, and then the next one along is normal. And what is abnormal on that scan is the lateral ventricles are dilated. And so when we see the lateral ventricles dilated, either it might be a pressure effect like you've got some aqueductal stenosis, or it might just be that the brain has not developed the cortex so much, so there's more space for the fluid. If you look at the bottom right hand, that's a fetal MRI, and fetal MRI is actually a very good tool these days for looking at fetal brains. And what you can see in this one is in the right hand, bottom right hand, is the normal brain, and you can see the cortex there is measured as 8 millimeters. The one next to it is a Zika-affected brain, and you can see the cortex hasn't developed. So you may not get microcephaly, you might just get a normal-sized skull, but actually the brain inside is not developing normally. So as I said, you would want to take a travel and a symptom history for what it's worth with the symptoms. If it's less than 14 days, so they're in that window where they may have blood or urine containing virus, then consider doing the testing on blood and urine, and I would probably do both. Now, because there were so many microbiologists and infectious diseases and virologists involved in developing this guideline, there is actually in the laboratories a lot of knowledge out there, and I would say most labs, if you ring them up, will have somebody who was on that committee who has a real interest in it. So if ever you've got someone you're wondering whether to test or what to test, you can pick up the phone. I realise I've been told GPs just have 15 minutes, but this is one of those situations where if you're not sure, just pick up the phone. If the woman has the testing and it's positive, then refer it to your local fetal medicine unit. And so there's 2 in Auckland, one at Middlemore, one at Auckland. And then in Wellington, there's one at the Wellington Hospital, and then in Christchurch for the South Island. So if you have a positive infection, refer it on. If the testing is negative, so there's no evidence of infection, it could well be that the infection has cleared, but it has actually happened. And so in that circumstance, we recommend ongoing ultrasound scans to keep reviewing to ensure that the fetal brain is developing normally. One of the real issues we had was about capacity when we first developed this guideline, and one of the major issues was, well, if we've got all these women coming back from Tonga in summer and then they need scans in the community, how will we manage? And all the way through that first sort of 3 or 4 months, I was in communication with all the ultrasound providers in the community in South Auckland and sending out guidelines and ideas to them, and they managed it fine. There weren't that many women, they had the capacity. But this was one of the things, was that by adding that in, we realised it could suddenly change the amount of scans that were required and whether we could manage it. So we were very careful to monitor that as we went. So there's a whole lot of unintended consequences around putting out a guideline like this at short notice. So what about neonatal presentation? Well, I will just say I am not a neonatologist or a paediatrician, but I've been working with Simon Rowley, who lots of you know is a neonatologist in Auckland, and he's been working with the paediatric surveillance unit based in Otago. And so between them, they're coming up with a paediatric guideline for paediatricians and not for primary care physicians. But I had to talk to Simon about where they're at with that. So that's kind of almost ready in a way. But I thought I would just talk about on one slide what would be useful for you. So a neonatal presentation is rare. So we haven't seen, as I said already, a lot of Zika cases. We've had around 8 women who have been through in the last year. So this is a rare condition, which is why I'm thinking, a long talk is of interest, but it also shows you what it can be like trying to deal with an evolving situation. We're still having new stuff come through. And this is the area that now has become quite murky. So almost in a way, the antenatal period, we've kind of got that sorted. We know that it definitely causes these issues on scan, and this is how we test for it. And yes, we now know that it's worth doing an amniocentesis. But now the paediatric surveillance, that's the quite murky area where people still haven't got a good grip on how you do this. What we're seeing is that it is rare. If it's at birth, then it may be because she was that woman who comes through and we know that the amniotic fluid showed Zika virus. It might be that at birth the baby is showing signs of a viral illness, or it might be the baby's born with microcephaly. That would be unusual because normally these women would have had scans to pick that up. In the first few months of life, the way that we're starting to see this pan out amongst babies is very much the way that CMV does. So in CMV infection, you can have a really terrible infection where everything is seen on scan and you've got those horrible brain pictures I showed you, or you can have a baby that looks absolutely perfect on scan all the way through. It's born absolutely perfect at birth, and then because of the fact that it attacks the optic nerve and the auditory nerve, you see as the child gets older, then there's problems with vision and hearing. And so we're seeing the same sorts of things with Zika virus. So if you're looking after a family where the baby, there was a travel history for the mum, and then the baby starts having problems with hearing or vision, then that might be a reason to be concerned. I asked Simon, I put failure to thrive. That's how old my paediatric training was. But he said, no, don't put that. He said abnormal development. So, if you're worried, it might be something that's thought about if there's a travel history, because that's the big if here. If you haven't got a travel history, then it's not relevant. So, advice to patients and partners. So this is the bit that Di was talking about. So this, I've just plucked it straight from the Ministry of Health guidelines. So for male partners of women who are pregnant or planning pregnancy, they should abstain from sexual activity or use condoms, even if asymptomatic, because we know 4 out of 5 people are asymptomatic, for 6 months following leaving a Zika-infected area. This is especially crucial if they have a partner who is or is at risk. I like the fact that it's at risk of becoming pregnant. If their partner is pregnant, they should abstain from sexual activity or use condoms for the duration of the pregnancy. So this is actually, when this came out halfway through last year, this actually made quite a big change, because a lot of the women were like, okay, I'll just stay at home, you're a businessman, off you go, you have your trips to here, there and everywhere, and that's fine as long as I'm at home. Suddenly it changed things quite a lot, that, some men who were in jobs that meant they would travel overseas to Zika-infected countries were suddenly double guessing whether they should. They might come back and their wife is pregnant or their partner is pregnant, they have a condom and it breaks, and then you're worrying about, well, what's the risk? And so this has created, I think, quite a lot of anxiety for a range of people. So what about for women who are planning pregnancy? So we've gone from the women who are pregnant, because the women who are pregnant, we're telling them, don't travel. Whereas, before we were a little bit not sure, we said take precautions. But if you're planning a pregnancy, we're now saying don't travel to Zika-affected countries. We're recommending that if women do, that they do use sensible precautions to try and stop themselves from getting mosquito bites and use contraception. And that if they're coming back from a Zika-affected area, to avoid pregnancy for 8 weeks. And this is around not knowing how long the virus is present in the circulation. And these are still things which are being worked out. And so most jurisdictions around the world have always gone for the longest length of time on the basis that we have a small amount of information as to what is the longest possible. So 8 weeks here, and much longer in semen, because it seems to stay longer in semen than it does in blood. If their partner has travelled, it's the same crossover as the previous advice. It's 6 months waiting. So now just a couple of cases. So I've tried to dream up a couple of situations that you might face on Monday. So we're going to first hear about Miss AB. She's a 32-year-old G4P3 Tongan woman. And she's just delivered her baby at your local hospital after returning home to New Zealand at 36 weeks. She's unbooked, had a normal vaginal delivery, and she's self-discharged from hospital. Your midwife, your local midwife, calls you. She's visiting her at home. Miss AB is well and recovering. The baby is fully breastfed and 48 hours old. Wet nappies. She's heard about Zika from her family and is worried about breastfeeding. What should I say? Do you think you might get that phone call? Okay, I'm going to take a straw poll, because there's 2 answers, isn't there? Yes, carry on breastfeeding. No, better stop breastfeeding. Okay, hands up if you're yes for carry on breastfeeding. Okay. Hands up if you're no for stop breastfeeding. Oh, you guys, I can't teach you anything. Okay. So, although the virus is detected in breast milk, transmission of Zika virus infection through breastfeeding has not been described. So there is no current recommendation to discontinue. And as most things with breastfeeding, often the benefits of breastfeeding outweigh the risks of breastfeeding. HIV being probably the only exception that we think about in terms of infections. So really, you can reassure the midwife, reassure the woman, carry on, but would she like some contraceptive advice? And please next time book in your pregnancy. Okay, so this is the next one. This is a different lady. This is Mrs. CD. She's 29 years old, and she had a 2-week holiday in Tonga 6 weeks ago. You can see her just lying on the beach. We'd all quite like to be there, I think. She's planning a pregnancy this year. She's been to the gym, she's taken her folic acid, she's doing everything. But she said, I need to have a Zika test because I went to Tonga. So what are you going to do? Yeah. I think the first thing I was going to do is take a bit more history. Has she used any precautions to stop getting bitten? Did she get any bites? Did she have any symptoms? Check with the partner the same questions. The screening serology is not recommended, as you said, Di. She's past the period of time when the reverse transcriptase PCR will be there. But what is very confusing in New Zealand, and if she's been on the internet and read, she might have looked at some other countries' advice, is that in some countries they would offer serology. So has she developed antibodies that might suggest she might still have a little bit of Zika around? And so she might come in asking for antibodies so that she knows, well, in my next pregnancy, I'll go back to Tonga and I won't worry about it. And I want to know for all my pregnancies if I'm at risk of Zika. The problem that we had was we had a lot of big and in-depth discussion with our microbiology colleagues about whether to include serology testing. And if you look at the American guideline, they are. And then also if you look at the Australian, they are. The problem is how you interpret the serology. And we felt that we couldn't provide a really good way of interpreting it and working out what to do. So I already deal with toxoplasmosis and CMV, and if any of you have ever had a woman with that, it's incredibly complex, because if you have toxoplasmosis IgM and IgG, that toxoplasmosis infection could have been anything up to 2 years earlier. And you're now in a pregnancy trying to work out what to do with that information. And someone might, with all the best will in the world, have just screened for it without having thought. So the same issues apply to the Zika virus, which is we don't really know much about the time lag for the IgM to go up and come down, and then for the IgG to develop. And we don't have the avidity testing that we have, say, for CMV, that gives us a bit of a better idea of what's going on. The other thing that we particularly have with Zika, which is where all the microbiologists were very het up about it, is that there's crossover with yellow fever and dengue. And where you could argue, well, yeah, you've gone to Tonga, we're not expected to have that. But where you have Zika virus, you have the same sort of mosquitoes that have the same infections, dengue and yellow fever. They're often co-located in similar geographical areas. And it's very difficult to actually tease out which one is the Zika. I didn't understand all the conversation, but I agreed with them, and we took the view not to do serology. And therefore, Di, you're absolutely correct, she's outside that 2-week time frame where we would expect to still see it in the urine. Sure. So if she had Zika, could she pass it on to her partner? Well, I guess it's in vaginal secretions, but I don't think there's been much research as how long it's in vaginal secretions. I'd imagine that it's out of vaginal secretions the same time frame as blood. I don't know that for sure. Semen seems to be different in that the semen seems to actually harbour it, and it seems to be there a lot longer. So I don't think that would be a major issue.
If New Zealand isn't choosing not to collect that information, doesn't that mean that we won't ever come to learn that? Because if we were collecting it, you could look prospectively back and find out the relationship.
So the reason we decided not to collect it was about creating the environment of, for that individual woman, of anxiety, which would take us down that pathway where we'd end up doing a lot of invasive tests that didn't need to be done. And we were still at a point of evolving information and the accuracy of those tests. So I see what you're saying, that a retrospective kind of approach to the data would be useful and interesting, but at that point in time we were more focused on the best for that individual woman on the limited information that we had. Yep. I have to say also, coming from the point of view of dealing with women who have had a type of screening for CMV and toxo and then teasing out all of the issues, it creates incredible anxiety. Most of the time, I don't think the testing was indicated. Yeah. And if you're going to screen, then you should just screen everybody. I'm a big fan of, if you're going to introduce something as screening, you do it in a way where you've got a clear plan. So we didn't feel we had a good handle on how to deal with those, and we didn't think anyone else did, but we thought they're all doing it because they thought, we've got the test, we should just do it.
I do travel medicine, so this was really big for us last year. Yeah. And the group that was really complex were the couple maybe in their mid to late 30s who had their holiday booked and then were coming back and very keen to start their family afterwards. Yeah. And they were a really hard group to work with because delaying by 6 months is a long time. Yes. And they were ones who I think we would sometimes, my colleagues would talk to microbiologists, and some of them I think did get some screening. Yeah.
And I think that's right. That's why we had all those microbiologists and we said ring, because there were situations like that where we thought it might be a helpful thing to do. I think the time when it's really hard is if you do the screening in pregnancy, but I think as part of your pre-pregnancy workup for a very specific situation, absolutely. And I think the microbiologists were great. They were all very keen to be run by people, and they were very much open to individualising what was done. Yeah.
We're talking about Samoa and Tonga, but what are the other countries that we've really got to be cognizant about for being high Zika risk?
Well, there's basically I get emails every week from the WHO, so there's always an update. And so you could say one country one week and then it won't be that country the next week. But I think currently those are the two major Pacific islands, and then the others are mainly South America, so Brazil, Colombia, Ecuador, some cases in the US as well. And I think if you've got someone who comes in and asks you, the best thing to do is just go to, if you type in WHO, Zika, current risk, I think it comes up and there's a map and you can look at it, because it does change quite regularly.
This is all about risk management. What is the incidence of microcephaly, or of problems in countries where it's endemic? In other words, what's the worst possible risk it could be for a particular woman who's at maximum risk?
Yeah, so that's a really interesting question. And actually, what has been done looking at the South American countries, we're just starting to get some of that data out. So part of the problem was that in those countries, they don't have good data collection. So these women were in the favelas, the poor part of town, the babies didn't get followed up. And so the original kind of case reports, it took a long time for people to get a grip. But it seems like the cases in Brazil, they had a much higher rate of fetal neonatal affection versus infection compared to some of the other South American countries. And there has been a lot of theories and question as to why in Brazil in particular, you know, for every, so if you said, and I'm trying to think, if you said 100 women in Brazil got a Zika infection, you know, in Brazil, I don't know if this is correct, I'm sort of plucking numbers a bit here, maybe 2 babies got affected. In other countries, it would only be 1 in 500. So whether that's a local genetic susceptibility, whether it's a more local variant of Zika, I'm not sure. So it's not clear that there is a standard rate. Okay, so like in CMV, for example, we will say, okay, if you have this in early pregnancy, then, you know, 20% of babies will have an infection, and if you have it at term, 80% will have an infection, but, you know, the 20% have an infection, 80% will be affected. So we've got some quite good statistics for those other viruses. But Zika, we're still kind of getting those statistics, but it does seem a bit different in that it seems that in Brazil in particular, because this had been around for a long time in Africa and they hadn't seen microcephaly in Africa despite having the same virus in the 20 years before Brazil, they just hadn't seen it. So whether it was kind of a new population that was somehow more susceptible, we're not quite sure. So good question.
More locally, what was the incidence in Tonga and Samoa, as opposed to Tongans and Samoans in New Zealand? Were there a number of babies born over there?
I think we've seen I'm not aware of any babies being born. So I think for us in New Zealand and the Pacific Islands, I'm not aware of any cases that have occurred. And talking to Simon, he's not aware of any either. So I think in a way, it was a very scary year for a lot of women and their families, but actually the way it translated into New Zealand and into the Pacific Islands wasn't that extreme microcephaly. However, what we still don't know is what's going to happen over the longer term for those children who might be at risk of more subtle problems, hearing and vision. And so I think there is a place for the paediatric surveillance unit to actually have something in place for, you know, following up.
It strikes me that it's got some, sorry, I've got a sore throat, but it strikes me that it's got some pretty serious public health effects, and changing people's relationships for 6 months is really important.
Yes.
You know, there's a little bit of a cynical part of me which would say, if there was a pharmaceutical involved in this, would we be getting this data faster? But because this is just a public health behavioural change that we're asking for, we're not finding this data. Like, I think we should know how long this Zika virus is viable in semen. I mean, it seems something that should be being monitored, like the person who questioned at the beginning. These seem important core questions to me.
Yeah.
Do you think there has been a slowish response?
Well, I think, yes, I think there has been a quite slow response to those questions. Certainly from the sort of big pharma point of view, I've actually got a friend who works in big pharma. They have focused very much on immunisations. So there's been a lot of work looking at immunisations, and then there's also been the more recent CRISPR work looking on, you know, changing the mosquito DNA. But in terms of like information gathering, I mean, we've tried really hard in New Zealand. Certainly we have, I say, 2 databases, we cross-reference, we've tried hard right from the beginning to keep that data, and the Paediatric Surveillance Unit are trying to keep their data. But I do think that internationally, it feels like there was a lot of scrabbling around last year, and then suddenly it's in semen, and suddenly no one knows how long. Yeah, I agree. I think if there had been some big money behind it, maybe it would have got sorted out a bit more. Yeah.
Does anyone else have any other questions?
Primate-only illness. Is it a primate-only illness? Because if we can look at animal models, it would make life much easier.
Yeah, I don't actually know the answer to that. Yeah. Someone else might know the answer. Our travel doctor might know the answer. Was it monkeys first? Yeah. Yeah.
Oh, at one stage, was the Brazilian government telling people not to get pregnant for 2 years? And was that information taken on board as a public health message? Like, are the birthing units in Brazil now eerily quiet at the moment?
Well, I think part of the problem is that the populations where this happens are the poorest populations, and because it's a Catholic country, then access to contraception is somewhat difficult. And so I think this was one of those situations where the Pope said it was okay to use condoms, which had never happened before. So I'm not aware of birthing rates falling particularly, but I think that's partly through women's access to contraception and their ability to afford it, rather than anything else.
Has anyone come across this clinically in their surgeries?
Oh, yeah.
Questions or a positive result?
PhDs in like South America. So I look after a number of people who come backwards and forth from Brazil, etc. But the ones who go to Brazil normally know more about it, or as much as I might.
Yeah.
But I do have others, and the guys aren't very happy about the no sex for that long a time. Well, yeah,
You can use condoms.
Sorry. Yeah, but the unrestricted activity.
I mean, I think the thing is that we've had 3 different versions of our advice in the last year, and I think probably we need to have a relook at that advice, but that's the advice as it stands at the moment. But I think you're right. What often happens is there's a lot of flurry and excitement, and a group is put together and the advice comes out, but then actually changing that advice as the risk comes down often lags behind what's available, because it's less of a panic. So I think you're right there. I probably need to go away and actually phone up and say, hang on, we need to change this advice or look at it again. Yeah. I would just say that I'm not keen to be involved in one of these again. It was a lot of crazy work at the time.
I saw a patient who I admitted, who was a Samoan lady who ended up with Guillain-Barré secondary. And I was wondering if you know how commonly that tends to occur with it, because it seemed to be something that was certainly sort of much like the microcephaly, sort of a marker or a warning that, or an association that sort of led us to first sort of notice the Zika virus.
So my understanding is that the Guillain-Barré is not that common. It's quite a rare complication. So we haven't had many cases in New Zealand at all, but then as you saw, our ascertainment is only 99 people infected, but there's only been 2 or 3 that I'm aware of out of that 99. Yeah.
Thank you.
Right. Well, when I spoke to Emma, she felt that she was unlikely to take the whole time for this presentation. Is there any more burning questions, or would you all like to sneak out and get in the coffee queue quickly? I think it's the coffee queue. Thank you so much, Emma.